the normal EEG and some patterns, either artifact or benign patterns, which can be mistaken for the epileptiform abnormality. So if you are familiar with those patterns and if you can recognize normal patterns and this, your 80% of the EEG training is over. Because see, the identification of the spike per se is very easy, and I think when we discuss spikes, already people are started sleeping. So, and majority of the you or we will be able to recognize that these are the spike or epileptiform abnormality. So there usually will not be any difficulty. Majority of time problem happens because of the false positive or over-diagnosis of the epilepsy. So now so basically once we have discussed that what are the criteria to identify spikes or epileptiform abnormalities. So the major differentiation when you want to identify spike or epileptiform abnormality, our idea is to differentiate whether it's a focal or a generalized epileptiform pattern. So if you can differentiate between focal and generalized, that itself is solve the majority of the problem, because that will be what we are doing for the medical management, isn't it? And then even after diagnosing that, if you can differentiate whether it's a frontal, parietal or some kind of generalized epilepsy, that will be bonus. So let us see this EEG. Anyone who wants to read this one? कोई भी? यहाँ पे क्या थोड़ा बड़ा हॉल है सब ऐसे. अच्छा आप बोलिए मैडम. हाँ.
This is EEG recording of 27 years old lady.
Okay.
And the settings are low frequency filter is at 1 Hz and high frequency filter is 70 Hz. Sensitivity 100 microvolt per centimeter. Paper speed is 30 mm per second. And notch filters is on. And it is bipolar longitudinal.
Okay, very
and
good. So always start with this technical aspect. Okay, so good that you recognize that. Now?
And it is bipolar longitudinal recording
Okay.
with the left side recording on the up, and it is in blue, and the background is about 6, 7, 8, 9, 10 Hertz.
Okay, good.
So it is alpha recording and background, and it is symmetrical, bilateral.
Okay, good.
And regarding abnormality, we are seeing a phase reversal at F7.
So there is some form of transient waveform or a paroxysmal activity which is standing out of the background, isn't it? Okay, so now this is where it is the first thing. What is the location and morphology?
Location is on the left side, frontal, F7 is
Okay,
the...
so it is seen in the left temporal chain, isn't it?
Huh.
And so as it got a field.
Yes.
Okay, so when you mean by field that at least it is involving the adjacent electrode and not confined to the one channel. And now you localize where is the maximum.
Maximum is at F7.
Okay, good. So there is a phase reversal across F7, bipolar montage. And apart from that, what do you think? You think it's a epileptiform or some kind of benign variant?
It is disturbing the background.
Okay. So it is standing out of the background. It has got a field, a physiological field with phase reversal across F7. And then there is a significant after coming slow wave. Okay. So this is a F7. Sharp wave, spike wave?
It
Spike?
is means less than 70, 70 to 100.
Okay.
So
will you be
sharp
able to count this as a 70 millisecond and this?
sharp.
So people are preoccupied with phase reversal. Then this sharp wave, spike wave or spike wave discharge business, this doesn't carry any significance. If you call it as a sharp wave or a spike wave discharge, meaning will be same. So this is more of a theoretical discussion. So it is a epileptiform abnormality. We can call them spike wave discharge over the left temporal region, left anterior temporal. Anything else apart from that? If you see the more thing.
In the left sided, at just before that, there is
Yes?
slowing, means
Okay. So this slowing is not less prominent. You see very, very significant slow wave, not only here, but even also in the following that, almost for the 2 second, there is a slowing which is different from that spike. Okay? What kind of slowing is that? Whether it's a polymorphic or polymorphic, and whether it's a delta slowing or some theta slowing. So you see, this is a one big waveform in 1 hertz almost, or 1.5 hertz. This is also again a very big slow wave.
Yes, sir.
On this slow wave, you may see some other beta or alpha activity, but this is a big slow wave. There is so it is a delta slowing which is polymorphic, which again it's a significant, isn't it?
It is symptomatic.
Okay, so yeah, probably it will indicate that it is a symptomatic focal epilepsy. So you know that it is a focal epilepsy from the left anterior temporal region with a slowing over also same region, likely to be a symptomatic etiology. Okay, so that is the thing which you would like to know from this page. Okay, now you think that this has a temporal spike, means the patient has temporal lobe epilepsy? Obviously, because it is coming from the temporal region. So temporal spikes are very common in patients who have extratemporal epilepsy, occipital or frontal lobe epilepsy. So temporal lobe acts as a sink. So all the intraictal discharges or even ictal discharges tend to go to the temporal lobe and manifest as temporal lobe. So presence of the temporal spike per se will not indicate that temporal lobe epilepsy. But yeah, practical purposes, if you can decide that this is a focal epilepsy and from the left temporal lobe, that is enough for the medical management. So if you now, do you want to see the rest of the EEG, or that is enough?
Average. Just
Average.
for confirmation.
For what do you want to confirm in this? Looking at average, how it will going to help you? Average है तो हर बार यूज थोड़ी करना है, फिर वो तो थोड़ा टाइम भी तो वेस्ट करेगा. So if you want to look at the whole of the EEG further, क्या एक पेज तो हो गया, हमें पता चल गया फोकल एपिलेप्सी. हाँ बोलो. अच्छा, okay, one is for that persistent slowing, then
Evolution.
Evolution of what? So you would like to see whether there are any other epileptiform abnormalities, especially one temporal lobe can have bilateral temporal lobe abnormalities. So bilateral temporal spike है कि नहीं है. So that usually matters in the surgical decision making. If there are some generalized discharges also you would like to know. So this patient have a tendency for generalized seizures if there are generalized seizures. Okay, and sleep में बहुत ज़्यादा activation हो रहा है कि नहीं हो रहा है, ठीक है. So all these things you would like to see. But 90% of your EEG is, if you can look carefully at this page, you have diagnosed that patient has a focal frontal lobe, left temporal lobe epilepsy. As we go forward, now anything else you see on this?
Slowing.
Where?
At T3, T5. Again, the phase reversal is there.
Okay, so there is a sharp wave again on the left temporal. Anything else?
But here spike is not there. Little bit.
This one is a sharp wave. If you see in average, it will be definitely become better. But apart from that, any new thing? What we have already seen? So इसको बोलते हैं टेलीस्कोपिक विजन. एक जगह पे फोकस हो गया. थोड़ा ऊपर नीचे करके देखो. राइट टेम्पोरल, लाइट टेम्पोरल लोब में. लुक एट दिस एरिया. नहीं, ये एरिया स्लो है कि नहीं है ये वाला? See this, there is a significant polymorphic delta slowing on the right side also. Okay, so that is other side is also becoming slow. So will it indicate that patient has bilateral temporal lobe epilepsy or bilateral structural pathology? ऐसा तो नहीं होगा.
Seizure can spread to other side also.
Okay, that is, but even in unilateral temporal lobe epilepsy, bilateral spike and slowing is very common. So that will not indicate that patient has a bilateral temporal lobe. So now you see there is a significant again slowing in the
Right side.
right temporal lobe also. So slowing is bilateral. There are broad sharp wave discharges on the Abhi?
Now, at the right,
Okay. So,
there is phase reversal as F8 also, but it is very spiky, spiked.
okay. So what do you want to indicate that it is very spiky means kya? So you mean it may not be a epileptiform? ऐसा कहना चाहते हो आप?
No,
हाँ.
there is field.
Okay.
Field is there.
फील्ड तो BSSS में भी होगा ना?
Along with that wave is also
So
there.
significant, you see, this is after coming slow wave, big slow wave, and this is a typical spike and wave discharges, phase reversal across F8. Now sometimes phase reversal becomes difficult because अगर आप फेज रिवर्सल इस वेव का फेज रिवर्सल लोगे तो ये तो ऊपर जा रही है, तो यू विल थिंक दैट इज F2 स्पाइक. So basically what we see the most prominent waveform. In this one is the most prominent, this one is prominent. So phase reversal is at F8. So this patient has bilateral temporal slowing and bilateral temporal spike. Okay, and then significant, if you see there's significant slowing in this. Okay. So this is the one pattern of focal epileptiform abnormalities which we'll see. This is the most commonest epileptiform abnormality जो spike you will find in routine EEG, temporal spike, either unilateral or bilateral along with polymorphic or rhythmic slowing. So commonest आप जब routine scalp EEG करते हैं तो this kind of spike and slowing will be seen. Okay, so this is here the differential diagnosis sometimes you don't have to miss is whether it is a benign variant, either wicket wave or BSS जो हमने last time discuss किया था. That thing we need not miss it or not overdiagnose it, but otherwise this is the one pattern of focal epileptiform abnormalities, temporal pattern or temporal spike. Okay?
Yes.
Great. चलो अच्छा कहाँ गया? Okay. अभी कोई और डिस्कस करना चाहता है क्या? ये दूसरा EG है, सेकंड EG. Anyone else? किसी और को भी डिस्कस करना है? कोई करना नहीं चाहता? अरे भाई कोई भी स्टूडेंट करो यार, इसमें कैसा डिस्कस, यहाँ कोई एग्जाम तो हो नहीं रही है. एनीवन? इनको दे दो, इनको बोलना ही है भाई, कुछ नहीं है. व्हाट डू यू थिंक इन दिस? ओके, वी अंडरस्टैंड दैट टेक्निकल फैक्टर एंड एवरीथिंग इज इम्पोर्टेंट. Correct, and this is a bipolar montage.
Bipolar montage, longitudinal bipolar montage. The left is marked in blue and right is red. And,
Okay.
Sleep record and so frequent.
So you don't see a well-formed background at least,
yes, sir.
Isn't it?
Yes, sir.
And
frequent spike waves are distributed over. I can see in the right parasagittal.
Parasagittal. What is that? Parasagittal means?
वो तो FCZ होगा ना.
No,
Parasagittal.
Frontocentral, sir.
Yeah.
Right frontocentral.
Okay.
Left anterior temporal.
Anterior temporal.
Left.
So there are repetitive waveforms, paroxysmal activity with a morphology of a spike wave discharge.
Spike wave
Okay.
discharge, yes, sir.
तो वो तो दिख रहे हैं.
हाँ, sir.
Bipolar में, if you see, it is seen on both the hemispheres. It is seen anteriorly. अब इसका जो आप इसका
Sir, I want to see the average montage.
अरे भाई क्या एवरेज मोन्टाज? एवरेज मोन्टाज इसमें देखो ना, दिस वेव फॉर्म, इफ यू सी दिस वेव फॉर्म,
Yes, sir.
this is FV2 F4.
FV2.
Okay, and this is the wave form. So where is the maximum negativity?
Sir, FP2.
Huh? This is going up.
FP2.
So FV2 is negative as compared to F4.
yes,
So
sir.
maximum negativity is in FV2.
FP2.
So FV2 is the potential. It is not frontocentral. It is actually anterior frontal or frontopolar.
Anterior frontal.
Huh?
Yes,
So यहाँ पे भी दिख रहा है. Even this Fp2, F8, Fp2 is the maximum negativity.
F2 is
Now, if you see this F4, C4, F4 is also negative. So, it is a large
large
potential,
in the
large negativity,
FP2,
but maximum is in the Fp2.
FP2.
Okay? उसमें बाइपोलर लेने की क्या जरूरत है? कोई जरूरत नहीं है. अब आप इसको देखोगे तो these are the maximum right frontopolar spike which are almost continuously coming
very
rhythmically,
very frequent.
and some of them are being reflected on the other side
this thing
also.
field is spreading, I think, to the right.
So अब ये जो लेफ्ट साइड में है वो कहाँ पे मैक्सिमम नेगेटिविटी है? So you have to see whether
left side में FP1, FP, F3, C3, F3, left.
Last of the page देखो, you have a look at the last 2-3 seconds.
हाँ, yes.
Last में FP1, FP7 देखो आप. That is showing FP1. FP1.
okay.
और
So you
ऊपर भी
see channel Fe1, F3 and F3, C3. Large amplitude is where?
That is a little distance. उसमें large amplitude F3, C3 में दिखा रहे
Okay.
हैं.
So you think it is a over the F3 or Fe1? तो वो तो प्रिंसिपल हमें वही देखना है भाई. See this one, if you think is this going up? ये तो up जा रहा है ना? Even in Fe1, F3, this is going bit up, no?
हाँ,
So that means as compared to F3, Fe1 is negative.
negative.
Now F3, C3, it is going up. That means F3 is negative.
Negative.
So, but Fe1 is more negative than F3. No?
F3.
So the
So
highest amplitude will be
FP1.
Fe1.
FP1.
Why this F3, C3, if you think now is showing a higher amplitude as compared to Fe1, F3? What is can be the explanation? क्या लगता है? उसमें higher amplitude क्या है? क्योंकि उसमें Fe1 is the highest negativity. Yes, very good. So, obviously the difference between F3 and C3 is more as compared to difference between Fe1 and F3. So, more the difference, more is the higher amplitude.
Higher amplitude.
So, bipolar montage don't go by the amplitude. Okay, if you sometimes, majority of time you will mislocalize. So, depending upon the phase reversal and this principle we go. So, these are, and now you see whether these spikes on the left side are independent or they are synchronous with these spikes.
Sir, it's synchronous.
Okay, so majority of time these are synchronous with this kind of spike.
I want to see further epochs whether any independent spikes are there
Okay, very good.
in the left.
Let us see the further epochs. Some of them have a tendency to become generalized. Then there are probably, if you see, look at here,
This thing.
this is the
asynchronous
spikes on
ones,
the posterior temporal.
Yes, sir.
But we'll not go into that detail. Let us continue on this page. Okay. So this is another second pattern of focal epileptiform abnormality. You will see. First we saw temporal pattern. Other is this anterior head region pattern. Frontopolar or frontocentral spikes, frontal lobe epilepsy, and isolated lateralized frontal spike means only on the one side are very uncommon because frontal lobe
Always
has very strong connection with the bilateral, both the frontal lobes, and they are very nearly situated. So the majority of spike may be bilaterally expressed. Like this maximum spike, we know that it is on the right side, focus is on the right side, but spike are expressed on the left side also. So only in 1/3 of the frontal lobe epilepsy cases we'll see unilateral focal spike. Another 1/3 will have either, or maybe more than 1/3, 40% will have either bilateral or generalized spike wave discharge because of the rapid spread and generalization. And approximately 1/3 of the patient with frontal lobe, typical frontal lobe epilepsy will not have any spike. So that is, you will see frontal epilepsy but without any abnormalities on the EEG because mesial frontal, basifrontal area, they are not covered with that, and the spikes which are deeper source will not be reflected on the surface. So this is the second pattern of spike. So first pattern is, commonness is temporal, then this anterior head region pattern. Okay, so these are the two types of focal spikes you will see. Okay, now anyone else want to discuss? अरे भाई किसी को ये कोई भी स्टूडेंट कोई भी हो आप बताओ सर माइक दे दो उस टेबल पे से कोई करेगा नहीं जस्ट डिस्कस ही इज दी वी आर नॉट अरे भाई एग्जाम थोड़ी है एनीवन आप ही ले लो हाँ चलो ऐसे तो okay we'll go straight to the business so these are bipolar montage okay what do you see why is the background
1 2 3 4 5 6 7 8 9 9.5
okay so you see this is awake patient you can see posterior dominant alpha activity on the right side isn't it so
But,
what is the difference between right and left
that right is looking normal and left there is a downward spiky pattern
okay
so
there
it is
are
going down so O1 will be negative as compared to P3
okay good
so and the frequency it is about that the spikes we are getting about 3 in
very
or
frequent isn't it
2.5 or 3 in 1 second or sometimes 2 also sometimes 3 also
okay
and
so one is that there is repetitive or almost continuous very sharp spike discharges which are occurring over the right posterior head region
yes.
obviously the maximum negativity is over the occipital region
yes
even T3, T5 and C3, P3 is involved. So there is a field also and very sharp continuous spike wave discharges.
and it is because more or less between 2 to 3 and we can say it
What
is
is
monomorphic
2 to 3 means what? What to
that frequency sometimes it is coming 3 sometimes it is coming
Okay,
2,
so
3 years.
how does it will matter whether it is coming 1 or 2? It is not going to change anything. So there is no need to split the hair. We know there are spike wave discharge and very continuous frequent spike wave discharges. Okay, and this is on the left posterior head region.
yes
Okay, if that much you can diagnose, your diagnosis is over. It is a left posterior head region epilepsy, left
yes.
occipital
Left
epilepsy.
occipital.
Now these discharges are very small needle-like. Okay, morphologies. And they are almost continuous like this discharges.
yes yes sir.
So these sometimes can give us some, and you see these are the almost continuous discharges. This one, if you are may sometimes try to see in the referential montage. Okay.
So it is a diagnostic of occipital spike because in average it is going up.
So these are occipital spike reflected in the T5. So it is not an electrode artifact. We know that this is a field. So this kind of continuous and very small needle-like spikes are characteristic of any particular pathology. So sometimes you can diagnose pathology also with this.
Benign occipital.
Benign occipital, okay. More than that, benign occipital spike will be a bit different than. Okay, so one is that usually this will be seen in patient with focal cortical dysplasia or gliosis.
Yes.
So occipital gliosis in our country is very common. But there will be, we expect that there will be some slowing if there is a gliosis. Here because of the very frequent spike, it's difficult to comment on the slowing. But intermittently, if you see background looks okay intermittently in between.
Yes.
So you will suspect that this is probably you are dealing with a focal cortical dysplasia. This kind of rhythmic, more than 1 Hz spike wave discharges is usually characteristic of focal cortical dysplasia. Okay.
Okay.
So these are the 3 patterns which will you see in focal epilepsies: temporal, anterior head region, and posterior head region kind of pattern. anterior head region spike going up, posterior head region spike going down in bipolar, and then in the middle there are temporal spike. And then you can have variation of that. So sometimes you can have multifocal spikes, sometimes you have a focal with generalized spike, but these will be the three patterns characteristically which we have to recognize. Okay? So these are the focal symptomatic epilepsy. वो बंद कर सकते हो भाई थोड़ी देर स्क्रीन. नहीं जनरलाइज अभी.
Sir, how can you differentiate between a bifrontal spikes and a unilateral focal spike with a contralateral expression? Similarly, how to differentiate between occipital spikes versus PHR spikes, which is expressed on the temporal region?
Okay, so Srija, great to see you after a long time. So, if there are independent spike, that is one spike on the right frontal and the left frontal is showing spike at the other point of time, so then you will know that this is a bifrontal epilepsy or independent origin from both the frontal lobes. If they are spike like in the previous case we seen they are synchronous, and we understand that this is a unilateral spike with a bilateral expression. Okay, that is the simple way. But in a given case, in a unilateral frontal lobe epilepsy, you can get bilateral independent frontal spikes or bifrontal spikes or even generalized spikes. So that kind of distinction is more theoretical rather than practical. Doesn't matter. If you can diagnose that it is a focal frontal lobe epilepsy, that itself is enough. Okay? Because in a given case, without other clinical details and this, and usually bifrontal epilepsy is very, very rare. The seizure originating independently from the frontal lobe UP. So, majority of time it is unilateral frontal lobe epilepsy, which can have bilateral frontal spikes or bifrontal spike means synchronous spikes on both the sides. Same thing happens in the posterior head region epilepsy. Isolated occipital, isolated parietal or isopedal posterior temporal spikes are very, very rare. In this case also, you see where there were very small spike, but it was expressed on the T5 as well as O1. So majority of the time, these are all posterior head region epilepsy have spike have a broader field, and that is why sometimes we call as posterior head region spike rather than the occipital and parietal spikes. So majority of the time, not majority, yeah, majority of time, there are individual cases like that where you have only occipital spikes or only parietal spikes. But because both frontal and occipital lobes have a strong connection through the corpus callosum and they are rapidly, even spikes propagate to the other areas. So they have a more broader field rather than in the case of temporal lobe epilepsy, you get a very focal anterior temporal spike, but that is usually not seen. So bifrontal or bilateral posterior head spikes are common in both these cases. Yeah.
Pediatric case also come to us in practice, and they come with headache. And first I used to diagnose as okay, it is migrainous headache, and I give like propranolol, low dose because they are children. But some children don't respond fully. So nowadays I am doing EEG in those patients. And sometimes they get generalized epileptic discharge, but there is no history of seizure. And so because they are not responding to propranolol, I start low dose valproate, and they respond to it. Then how long it to give, whether it is really generalized seizure, because there is no history of seizure.
But why we will do EEG in case of migraine?
It is looking like migraine, but it is not responding to propranolol.
50% of the patient of migraine will not respond to the propranolol.
And sir, in periphery, they are very enthusiasm to do EEG. Sometimes
So
they tell us, I have to go for EEG. Okay. And sometimes I get the finding.
So, see, migraine and epilepsy diagnosis is a clinical diagnosis. You cannot diagnose migraine or even epilepsy with the help of the EEG. In 50% of the cases of epilepsy, EEG will be normal. And in some 2-3% normal people will have epileptiform abnormalities. So we don't make the diagnosis of epilepsy based upon the EEG. I don't criticize, but this is a misuse of the EEG. Why to do EEG when clinically you have a classical case of migraine and which is not responding to propranolol? So now said that some 2-3% of migrainous patients have epileptiform abnormalities, either in the occipital region or sometimes generalized, which I would suggest may be a overdiagnosis of some normal variant. But some occipital spikes are seen in patients with migraines. But that doesn't mean that you have to treat with them anti-epileptic. And they responded to valproate not
That is, because
they-
it is epilepsy. That our
because that valproate has a anti-migrainous
Action.
property.
Role
That's
also,
why they
no?
responded
So
rather
that
than
is-
that.
yes, sir.
So that is a misuse of the EEG.
I think you can ignore the EEG findings,
Yes, sir.
control the headache,
Okay.
see the response. You can give something else instead of valproate. Because you can give flunarizine also, it is quite effective. Even topiramate can also be given if the child is not responding.
Actually, I started propranolol, then I added flunarizine. Even
Stop
then,
propranolol, then add.
So I think that
Don't
we
combine.
can discuss in the headache
Never
class
give.
now, rather than this EEG
Never
class.
combine. Migraine, the rule is never combine. Stop and add the other one.
माइग्रेन थोड़ी पढ़ाना है तुम्हें अब Okay, so don't do easy in such cases. But that is a routine practice. One of the senior most neurologists of Chennai, some 10 years back, told me when one of the EEG workshop that the commonest indication of doing EEG, first indication is headache and second indication is neuropathy. And then only if suppose subsided epilepsy comes. So that is the overall practice. And aim of this workshop is to dispel that kind of myth and try to avoid this kind of misuse of EEG. Okay, so good that you brought that topic. ये चालू करना भी. Okay, who will read this EEG full of vertex waves? आपके अलावा तो और कोई तैयार ही नहीं होता भाई, कैसे है? अभिषेक तुम्हारे यार किसी को बताओ. You want to discuss? Good, sir, please.
Sir, I will go directly to the point.
Yeah,
I can
very
see
good.
phase reversal at C3 and I think it is T3 and also over T4, and it looks like bilateral centrotemporal spike.
Okay, good. So you have directly hit over the nail. So, okay, this is likely to whether it is a sleep record. We don't see the normal alpha activity or something. And you see this EEG very frequent paroxysmal abnormality. And you can make out that there are multiple phase reversals, okay? C3, C4, T3 and G4. So, you see some difference between the two sides? So you compare left and right, amplitude is higher on one side or?
Yes, sir. It is more on the left side.
Yes, so obviously, and then these discharges which are there, are they independent on both the sides or they are same but synchronous?
They are same on both sides.
Synchronous discharges, isn't it? So they are bilateral centrotemporal spike, which is higher amplitude on the left side, and those are synchronous discharges. So same thing which happens in the frontal lobe epilepsy with bilateral expression can happen in the centrotemporal epilepsy also. Okay, so this kind of bilateral spikes and this multiple phase reversal in bipolar montage, double phase reversal, what we call central as well as temporal. So this is a characteristic EEG of
Rolandic epilepsy.
Yes. So it is a characteristic of sleep, very marked activation, very frequent spikes and bilateral spikes. So in 50% of the cases you will get this kind of bilateral spike, another 50% will get isolated unilateral spikes. Both are equally common.
Sir, I
So-
have queries, sir. One query, sir.
Yes, yes.
Somebody prefer treating this group of the patient. Somebody say this group of the patient does not require treatment. So I just want to know your view.
So again, we don't treat the EEG, we treat the patient. So if patient has very infrequent seizure, nocturnal minor seizure once in a year, then probably you may decide not to treat, okay? Because you know that this is a self-limiting epilepsy. Maybe after 2 or 3 years, it might remit. So, and for a infrequent seizure once in a year, why to give medicine for continuous 1 year? So you discuss with the family, and you may decide not to treat.
Thank
But
you,
if
sir.
seizures are frequent and disabling, then majority of us would like to treat that child to prevent the seizure, not the EEG. Now, there is no correlation between the seizure severity, frequency and EEG severity. Patient may be completely have very infrequent seizure, but EEG may be grossly abnormal. So, treatment decisions are not made by the EEG, whether to treat or not. But what to treat, EEG will help you to decide whether it's a focal or generalized epilepsy. Okay? Now, this is in the referential montage, same EEG. So, now you can see their maximum is in the T3, T4, C3, C4, and then you frontal, if you see, they are going down. Isn't it? So there
Yes.
is a, you can see there in the FE to F8 or even FE to T4, there is a phase reversal over here. There is a phase reversal over here.
Yes, sir.
Okay. So phase reversal we discuss in the average or referential montage is very, very rare. It usually indicates is there is a contamination of the reference, but this is the only one condition where you get more than one phase reversal in bipolar montage. So we saw some 4 phase reversal, usually double phase reversal, and true phase reversal in this montage, in the referential montage. Okay. So this is a classical EEG of benign Rolandic epilepsy. There can be variation, sometimes infrequent spikes. What will be the overall EEG characteristic of benign Rolandic epilepsy?
I think Tanya topology.
Now, what will be the overall EEG characteristic? What will be the background in this all epilepsies? वो तो occipital बता दिया.
Background usually normal, sir.
Background will be normal. What will be the awake EEG like?
Awake easy, sir, it is normal.
It's normal, or we show very infrequent spike, and then there will be significant activation during sleep, and sleep patterns will be usually preserved. Will get sleep spindles and vertex waves. Okay, and this patient, another benign epilepsy is benign occipital epilepsy. Overall patterns are same, but you can get some scotosensitivity or eye closure sensitivity in benign occipital epilepsy. These are as far as the focal epilepsies are concerned. We have to differentiate between benign and symptomatic focal epilepsy based upon some EEG characteristic. And if it is symptomatic, what is the source, frontal, temporal, or posterior? So this is how the overall, we can not show you all the EEG, but overall flavor of the focal epilepsies.
कितने
अच्छा ये नहीं खुलेगा, इसमें उन्होंने डाला नहीं है सॉफ्टवेयर. एक देखना सॉफ्टवेयर डाला कि नहीं. ये है तो सही है.
अगला खोलो, फोल्डर है बस, फॉर्मेट ऑफ द फाइल 278 की भी है ना, नहीं खुलेगा ये वाला डालना.
ये पर खुलना तो चाहिए, इसने इसमें डाला नहीं है. मेरा वाला लैपटॉप लगा देंगे.
तो लगा दो. चलो ठीक है, ये कर लो.
ओके, तुम डिस्कस करोगे.
आप करो, मैं साथ में खड़ा हूँ, कोई बात नहीं।
ये ऑन करना भी। ओके, एनीवन? व्हाट यू सी इन दिस ईईजी? कोई और बताओ भाई, कोई ऐसे बोलोगे नहीं तो कैसे? आप ही बोल लो मैडम। हाँ, इनको देना।
It is a EEG recording of 9 years old child.
Okay, we'll go directly to the point.
Okay. It is a hyperventilation recording.
Okay.
And background, it is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11.
Oh, which second you are counting 11? I think best background where you see is probably here.
Okay.
1, 2, 3, 4, 5, 6, 7, 8, maybe 8.5.
Okay.
अरे क्या है? तो शुरू किया है. Okay. Apart from that, what you see? Anything else? We'll go a bit fast.
In the last means recording, some slowing we are noted.
This one. What is that? What is likely this one? We have discussed several times. This one also. So these are posterior slow waves of youth. It's
Yes.
not abnormal slowing. We'll go forward. There are some slow waves are appearing. Still go forward. हाँ भाई, तो आइसोलेटेड पोस्टियर स्लो वेव्स तो आ ही सकता है ना हाइपरवेंटिलेशन में, हैं? उसमें क्या प्रॉब्लम?
इसमें generalized slowing.
Okay, so you see in the hyperventilation there are generalized burst of generalized slow wave discharges. And now this, what is happening this? Okay.
इसमें 3 first, it is starting from 2, then it is going to 3.
No, what is it is? So you, what do you see? You see a generalized burst, no? From anterior to posterior and from on the both the hemispheres. Okay.
Yes, sir.
So this is a generalized burst of spike wave
Spike and
discharges.
wave discharges.
Isn't it?
Yes.
And happening during the hyperventilation. कहाँ गया? पीछे चला. Okay. नहीं, आगे चले गए. With a frequency of
3 first, it is
अरे भाई,
it is increasing
लैपटॉप
actually.
इसका सेंसिटिव है. हाँ, सर मेरी Okay.
चल
It is the frequency is increasing. First is
frequency.
कहीं 2.5 आ रहा है, कहीं 3 आ
Okay,
रहा है.
so maybe slower frequency here, but in the mid initially you see there is probably 3 hertz frequency. Spike and wave discharges, generalized spike wave discharges with abrupt यहाँ पे onset with lasting for almost 10 seconds with abrupt offset and generalized during hyperventilation. So
Childhood absence
very good. So
epilepsy.
it is a typical 3 hertz spike wave discharges of childhood absence epilepsy. Important from the, rather than 3 hertz and this, it's the very uniform and very stable morphology of these discharges. So all the primary generalized patient or epilepsy patient have, these are very unique, very stable, very monomorphic discharges from discharge to discharge. And this morphology helps you to really decide whether it's a primary or secondary. So majority time this question will be there whether it's a primary generalized epilepsy or secondary generalized epilepsy, because treatment option will be different.
Yes.
So this kind of very stable, very rhythmic and monomorphic discharges that indicate that it is primary generalized epilepsy. In this case, it is childhood absence epilepsy. And usually this lasts for almost more than 3 seconds, may last up to the 8 to 10 seconds, sometimes 20 seconds. Usually in patient with JME or juvenile absence epilepsy also have absence seizures, but their discharges are of shorter duration, less than 3 seconds in JME, less than 6 seconds usually in juvenile absence epilepsy. So these are the usual, it's a very characteristic. You see the first discharge, and you see this discharge, almost the same, like a photocopy of the same discharge. Very stable, very monomorphic, and very unique morphology of these discharges. So these are because of the short time, we'll go directly to the point. Okay, so
Okay, 16 years old. The EEG recording of 16 years old
Okay.
female patient. And
Yes.
okay. It is also generalized discharges, spike and wave, and frequency is 3 hertz, and it is coming abruptly. It is anterior to posterior, that gradient, and
So again, very stable and very monomorphic kind of morphology. But what is the difference between the previous one and this?
time duration
Okay, one is short. Then
1, 2, 3, 3.5 seconds.
Poly spikes are there.
So everybody is telling this polyspike. So once it is polyspike, then it is not 3 hertz, because
It is more than
of polyspike is 1 hertz. So if you count in the list, even the first second itself it is 4 hertz or more than 4 hertz. So these are faster spike wave
Faster
discharges.
spike.
Polyspike is not 3 hertz spike wave discharges and of the shorter duration.
Yes,
But again, see the morphology, very
very uniform.
uniform, very monomorphic, very stable morphology. Okay? So this is unlikely to be childhood absence. Obviously, you have to correlate. In every patient, you want to be able to tell whether it's a JME or you can always, it's a generalized epilepsy or it is likely a genetic generalized epilepsy. Whether it's a juvenile absence or JME, we have to decide clinically. Okay, so this is another pattern of discharges which is seen in this short duration and that. एक मिनट ये देख लो हाँ खोल जाने दो हाँ बस बस okay in this one
On closing the eyes,
okay so
there are
so there are discharges when eye closure but these are again
spikes.
spikes and these are some polymorphic discharges polyspike wave discharges and on eye closure. So this we have to consistently see whether these are coming repeatedly on eye closure or not.
Okay.
So whenever you see with the generalized epilepsy, always check whether it is eye closure sensitivity and the photosensitivity and hyperventilation. Eye closure itself is the activation procedure, so that always we have to keep in mind. So it's eye closed and there is a generalized discharge, and if this patient has a photoparoxysmal response also, then it may be a case of eyelid myoclonia with absence or Given syndrome. But this eye closure sensitivity can occur in JME patient also. So it's not very specific, but if you can diagnose, again this G1 versus JME is a clinical diagnosis. Okay, भाई 2 EEG 2 मिनट चलो. अब वो सिम्टोमेटिक 1-2 हिप्स में निकाल देते. पीछे भी नहीं हाँ सिम्टोमेटिक हिप्स में 1 मिनट नहीं यही खोल दो.
ये फेस फिल्टर की होगा और तो मैं चैनल फोकल थोड़ी करना है.
यही कर दो.
होगा नहीं ना ये.
हो गया ना. ओके सेंसिटिविटी कम मत करो.
ये थोड़ा सा स्पाइक दिखा है ना कुछ.
अरे नहीं देख रहा है तभी तो बताना है इनको कि दिखता नहीं.
चलो ठीक है.
ओके व्हाट यू सी दिस.
Sir, frequent spike waves are there, and it's a sleep record, but background is a very high amplitude.
Impossible to make out whether this is a awake or sleep record, and impossible to make out anything out of this page,
Out of it,
isn't
yes, sir.
So once you see this kind of EEG, where is
Very
difficult to see any kind of background
chaotic.
and continuous, you can say full of spike wave discharges,
spike waves.
very angry looking
Huh,
EEG.
and high amplitude also.
and high amplitude, So you can reduce the amplitude and see. So chaotic background, multifocal spikes, spikes everywhere, like it is
More PHR
brain
dominant.
on fire, and this generalized
PHR
discharges
dominant generalized.
with this kind of burst attenuation,
Burst.
no background activity. So this is
Hypsarrhythmia.
hypsarrhythmia
Or like
any kind of epileptic
epileptic
encephalopathy
encephalopathy.
will looks like this. But when you have some organized background, this when the age advances, you have a Lennox-Gastaut syndrome and this. But this is a hypsarrhythmia pattern in a given clinical setting. So if you think EEG full of, there are maybe variation of this. We cannot discuss everything. But EEG full of spikes and you don't see any background or no sleep activity and continuous abnormality like that, then this is hypsarrhythmia.
Hypsarrhythmia.
Okay? Okay, this one. So at least you can make out some background, isn't it? And background it bit slow. You get very frequent spike wave discharges, frontally dominant. Some of them are generalized, and these are also well-formed large spike and wave discharges with a frequency of 2 to 2.5 hertz. These are slow spike wave discharges. The previously you saw that one and this one. So not very. And see the morphology, it is variable morphology.
Variable morphology.
As compared to those patients we saw with genetic generalized epilepsy, variable morphology,
Morphology is slow
erratic
spike wave.
discharges,
Frontally dominant.
frontally dominant. and
Background seems to be slow, sir. So it's probably some.
So this kind of slow spike wave discharges, very prominent spike followed by slow wave, frontally dominant, and slow frequency, less than 3 hertz. So 2 to 2.5 hertz. Slow spike wave discharges.
I would like to see for any focal fast activity or generalized fast
Focal fast activity.
or like generalized paroxysmal
Okay.
fast activities.
So that we've gone to see, you can see generalized paroxysmal fast activity, but based upon this pattern alone, this kind of slow spike wave discharges, this is a
LG.
so LGS. So when patient from West syndrome, they evolve to LGS, background becomes more organized.
Organized.
And well formed, but you have continuous multifocal spike, and again these generalized spike wave discharges becoming prominent during the sleep, slow background, again no sleep activity, and not all the patient, but 70% patient have generalized paroxysmal fast activity. So this is the characteristic EEG of
LGs.
LGS. So this is what we have tried to see, differentiate between focal and generalized, and genetic or idiopathic generalized, idiopathic focal versus symptomatic generalized, like West syndrome and this. If you can recognize this pattern, that I think should be enough for the initial majority of the diagnosis. In other cases, you will get many variation of that, but this is, I think, as far as epileptiform abnormality. Okay? Great. Thank you.